Did you know that a seemingly simple fall onto an outstretched arm, a common everyday accident, can unleash one of the most devastating and complex patterns of orthopedic injury?
It really can.
One so challenging to manage that it was historically, and perhaps justifiably, labeled the terrible triad.
That's the one.
Today we ask, are these injuries still as formidable, and how has our understanding and treatment evolved to tackle this specific kind of chaos in the elbow joint? Welcome to the Deep Dive, where we transform stacks of information into clear, actionable insights. I'm your host, and in this deep dive, we're tackling that historically ominous, terrible triad of the elbow.
A very significant injury.
This is a dive shaped specifically by the collection of articles and research you, our dedicated listeners, shared with us to help navigate the intricate anatomy, complex mechanics, and challenging treatment pathways detailed in these sources. I'm thrilled to be joined by an expert with a profound ability to synthesize dense medical literature into accessible, practical understanding. It's a privilege to have you with us today.
Thank you. It's a pleasure to be here. These injuries are certainly a significant challenge in orthopedics. And the sources you've provided offer a really comprehensive look at where we stand in managing them today.
And that understanding is precisely our mission. Because, as the sources make clear, this isn't just a collection of random broken bones.
No, not at all.
It's a specific, predictable pattern of failure in a joint built for both stability and complex motion.
Exactly. A delicate balance, easily disrupted.
So let's jump straight into the fundamental questions, setting the stage for our deep dive. If someone were to ask you, what exactly is a terrible triad injury? Beyond the scary name, what are the three absolute core components that define it?
Right. The triad refers to the three key elements that must be present simultaneously. Firstly, you have a posterior elbow dislocation.
Okay.
Secondly, a fracture of the radial head or the neck.
Right, the radius bone.
And thirdly, a fracture of the coronoid process of the ulna.
The ulna.
Yeah. It's the combination of this dislocation with those specific bony injuries that creates the profound instability characteristic of the terrible triad.
So it's the dislocation plus the radial head fracture plus the coronoid fracture. Got it.
That's the definition.
Second question. You mentioned a simple fall can cause this. What is the specific mechanism, the typical scenario, that brings these three components together in such a damaging way?
Well, the classic mechanism, described in the sources as accounting for around 60% of cases, is a fall onto an outstretched arm.
Right, the fail injury.
Precisely. The critical forces involved are axial loading, that's force traveling up the arm through the radius,
Okay.
combined with a valgus force, which is a bending force pushing the elbow inwards towards the midline of the body,
Okay.
and external rotation or supination of the forearm relative to the humerus.
So twisting outwards.
Yes. Imagine planting your hand slightly lateral to your body as you fall. This often generates the necessary combination of forces to disrupt the elbow, typically starting from the lateral side and progressing inwards.
Axial load, valgus, external rotation. That specific cocktail of forces from something as common as a fall is, well, it's quite sobering.
It is indeed.
And finally, going back to that name, why was this injury historically considered so terrible? What were the outcomes like in the past?
Historically, yes. Managing these injuries was fraught with difficulty, really quite problematic.
How so?
Even after they managed to reduce the dislocation and attempt some sort of fixation, the elbow often remained unstable, or, perhaps more commonly, became severely stiff.
Stiffness.
Exactly. The rates of complications like recurrent dislocation, the elbow just popping out again, and significant loss of motion were very high. Surgeons really struggled to reliably restore stability and achieve good functional outcomes.
Leading to long-term problems.
Yes, leading to long-term disability for many patients. The name truly reflected that historical difficulty and the high potential for a poor result.
That historical context certainly underscores the challenge. It sounds like the fight against instability on one hand and stiffness on the other is absolutely central to this injury.
That's the core dilemma.
Okay, let's unpack this further, diving into the details from the sources. To truly appreciate what goes wrong in a terrible triad, we first need to understand the normal elbow, its incredibly complex anatomy, and how it achieves stability.
Absolutely.
Yeah.
You can't fix it if you don't understand how it's supposed to work. The elbow is far more sophisticated than a simple hinge.
Right.
As the sources detail, it's actually a single joint capsule containing three articulations: the humeral joint, the radiocapitellar joint, and the proximal radial joint.
3 joints in one capsule.
Yes. It's described as a trochleogynglymoid joint.
Trochleogynglymoid. Quite a mouthful.
It is. It basically means it's primarily a hinge, but it also allows rotation.
So the hinge part is where?
That's the main articulation, the humeral joint. The trochlea, the humerus, which is shaped a bit like a spool,
Okay.
articulates with the greater sigmoid notch of the ulna. This gives you the primary hinge motion flexion and extension. And it's inherently quite stable due to the way the bones fit together, especially in full extension and near full flexion.
And the rotation comes from the radiocapitellar joint, is that right?
Precisely. This is where the radial head, which has a sort of concave articular surface, rotates against the capitellum of the humerus, the rounded end of the humerus on the lateral side. This allows for pronation and supination, turning your palm down and up. The proximal radial ulnar joint, where the radial head also contacts the ulna, is critical for this rotation too, and it's mainly stabilized by the annular ligament.
Okay, so bending and twisting are both happening here. The sources particularly highlight the coronoid process and the radial head as key bony players in the terrible triad. What are their specific roles in normal stability?
They are absolutely crucial osseous stabilizers, the bony parts providing stability.
Right.
The coronoid process, which is a projection on the front of the ulna,
Okay.
acts as an anterior buttress. It's vital for preventing the ulna from sliding backwards on the humerus, especially as the elbow flexes beyond about 30 degrees.
So it stops it dislocating backwards in flexion.
Essentially, yes. And what's particularly significant and often fractured in the terrible triad is a specific part of the coronoid called the sublime tubercle. It's on the anteromedial aspects.
Anteromedial, front and inside.
Correct. And this is the primary attachment site for the crucial anterior bundle of the medial collateral ligament, the MCL.
So fracturing the coronoid isn't just losing a piece of bone, you're potentially detaching a major ligament at the same time.
Exactly. Especially if it's a significant fragment involving that sublime tubercle or the wider anteromedial facet, as described by the O'Driscoll classification we'll probably come on to.
Okay.
Then you have the radial head. Well, the humeral ulnar joint is the main stabilizer in the bending plane. The radial head plays a vital secondary role.
Secondary. How so?
Particularly against valgus stress, that inward bending force, and also against rotational instability. It contributes up to 30% of the resistance to valgus forces.
30%. That's significant.
It is. And crucially, it's also a primary bony restraint to something called posterolateral rotatory instability, or PLRI. It helps prevent that abnormal outward twisting of the radius and ulna on the humerus.
Wow, up to 30% of valgus resistance. That's a huge contribution for a bone we often just think about for rotation.
Yeah.
It really highlights how interconnected these structures are.
Absolutely. Everything works together.
What about the main ligamentous stabilizers then, the soft tissues?
The static stabilizers, the ligaments and the capsule, are arguably even more critical for stability, especially against sudden forces.
Right.
On the medial side, the inside, you have the medial collateral ligament, or MCL complex. This is the primary restraint of valgus stress and also resists internal rotation stress.
Okay.
It has three bundles described. The anterior bundle is the strongest. It's taut from 0 to 60 degrees of flexion.
In main working range.
Often, yes. Then the posterior bundle is taut in deeper flexion, say 60 to 120 degrees. And there's a transverse ligament, which is generally considered less functionally important.
And you mentioned the anterior bundle attaches to the coronoid.
Yes, attaches right onto that sublime tubercle of the coronoid. This connection makes injuries to that part of the coronoid particularly destabilizing for the medial side.
Right, you lose the bone and the ligament anchor. And on the lateral side, that LCL complex seems key in the mechanism you described earlier.
Yes, absolutely. The lateral collateral ligament complex is the primary restraint to that posterolateral rotatory instability, the PLRI. It originates from the lateral epicondyle of the humerus, the bony prominence on the outside.
Okay.
Traditionally, it's described as having several components. The radiocollateral ligament, the annular ligament, which we mentioned, stabilizes the proximal radial ulnar joint.
Right.
The accessory lateral collateral ligament, and the key one, the lateral ulnar collateral ligament, the LUCL.
The LUCL is frequently mentioned in the sources as being paramount. Is it the single most important lateral structure?
Well, the LUCL is certainly often considered the main functional component of the lateral complex. Disruption of this ligament is consistently associated with PLRI.
Okay, however, it's maybe a bit more nuanced. Some biomechanical studies suggest that the entire complex functions more as a single unit, originating from a common footprint on the lateral epicondyle and inserting onto the ulna.
Like a sheet of tissue.
Sort of, highlighting the concept of a continuous capsulogamentous complex. There's also a thickening of the posterolateral capsule, often referred to as the Osborne-Cotterell ligament, which also contributes to stability, acting as a check rein against posterolateral rotation and varus angulation.
Varus is the outward bending.
Correct, the opposite of valgus. So while the LUCL is crucial, it operates within this broader, complex lateral network. It's not just acting alone.
That level of detail is really helpful. It's not just one simple rope holding things together. It's more like a woven structure.
A good analogy.
And you also mentioned the joint capsule itself.
Yes, the anterior and posterior capsules are also important contributors to overall stability. The anterior capsule provides some secondary restraint to valgus stress and also contains nerve endings contributing to proprioception, the sense of joint position. So it tells your brain where your elbow is.
In part, yes. And both capsules are typically torn quite extensively in elbow dislocations.
And finally, the muscles.
The dynamic stabilizers, yes. The muscles crossing the joint, like the inconius, triceps, brachialis, and the common flexor and extensor origins. By providing compressive forces across the joint during contraction and contributing to proprioception, they add another layer of stability, especially during active movement.
It's incredible how many different elements have to work in perfect harmony. The specific shakes of the bones, the tensile strength of the ligaments, the integrity of the capsule, and the coordinated action of the muscles.
It's a truly intricate system, built for stability during load bearing, but also for remarkable mobility for function.
And when you disrupt key players from multiple categories like this, bone, ligament, capsule,
You get the profound multiplanar instability seen in a terrible triad. It's not just one structure failing. It's a catastrophic, cascading failure involving bony blocks, critical ligaments, and the surrounding capsular support.
which brings us back to the mechanism again, but perhaps in more detail now we understand the anatomy. How do those specific forces you described, the axial load, valgus stress, external rotation, how do they specifically create this pattern of simultaneous bony and ligamentous damage?
This is where the concept of the hoary circle comes into play, which the sources mention. It describes the predictable sequence of injury progression around the elbow.
The hoary circle sounds like a map of destruction.
In a way, yes. It typically starts laterally and spirals around the elbow medially as the dislocating forces continue and overcome each stabilizer in turn.
So stage 1.
Stage 1 involves the disruption of the lateral collateral ligament complex. This initiates the instability, allowing the radius and ulna to start rotating posterolaterally relative to the humerus.
The outward twisting starts.
Correct. If the force continues, you progress to stage 2. This involves carrying of the anterior and posterior capsules. The joint is now actively dislocating or subluxating. But the medial side, the MCL, might still be intact, providing some sort of unstable hinge. However, in the terrible triad, the forces are usually higher.
Pushing it further.
Exactly, pushing into stage 3, where the medial collateral ligament is also disrupted. Now you've lost stability on both sides, plus the capsule.
And the bony fractures are a consequence of this progression. When do they happen?
Precisely. The terrible triad is considered an osseous extension, a bony consequence of this stage 3 disruption of the hoary circle.
Right.
As these severe forces overcome the lateral ligaments, then the capsule, and finally the medial ligament, the bones themselves start to fail under the stress. The radial head is forcefully impacted against the capitellum, causing it to fracture.
Smashed against the humerus.
Effectively, yes. Simultaneously, as the ulna is displaced posteriorly, the coronoid process acting as that anterior buttress and also the anchor for the MCL is sheared off or fractured as it collides with the trochlea of the humerus.
So it gets knocked off from behind.
Or sheared off by the force. So it's a progressive failure of the soft tissues culminating in these specific bony injuries occurring at the points of maximum stress or weakest structure. What's really insightful from the sources is that the bony injuries aren't just random events. They are a direct result of the extreme forces tearing through the stabilizing soft tissues in that specific lateral to medial sequence.
That sequential failure from lateral to medial, with the bony fractures being the sort of final breaking points, that paints a very clear, albeit brutal, picture of the forces at play.
It does. It helps understand why these 3 injuries occur together.
Okay, so a patient presents after this type of fall. Their elbow is maybe obviously dislocated or just looks severely injured. How do clinicians confirm the terrible triad diagnosis and understand the full extent of the damage?
Well, a high index of suspicion is absolutely vital, especially in the context of any elbow dislocation.
Yeah.
You have to assume it could be this until proven otherwise. The initial clinical evaluation involves a thorough assessment. Beyond any obvious deformity, you're looking carefully for swelling, bruising, and gently palpating for tenderness, which might indicate specific fracture sites or ligamentous injury points.
And critically.
Critically, a neurovascular examination is non-negotiable. You must check the radial pulse and capillary refill and assess nerve function, sensation, and motor power, particularly for the ulnar nerve.
Why the ulnar nerve specifically?
It runs right behind the medial epicondyle, so it's very vulnerable to being stretched or even trapped during the dislocation or by fracture fragments around the medial elbow. Assessing instability clinically can be very difficult in the acute setting because of pain and muscle guarding, though sometimes gross instability is horribly obvious.
Is there anything else you look for clinically? Any associated injuries?
Yes, always. Always remember the potential for associated injuries, particularly distal ones. Specifically, in the context of a radial head fracture with elbow instability, you absolutely must examine the distal radial sulnar joint down at the wrist.
The wrist joint. Why?
Because the interosseous membrane, a strong sheet connecting the radius and ulna along their length, can transmit force. A severe radial head injury, especially if it's comminuted or involves the neck, can disrupt this membrane and also injure the DRUJ ligaments at the wrist.
Ah, that's the Essex-Lopresti injury.
Exactly. That's the Essex-Lopresti injury, and missing it can have severe functional consequences later on, like wrist pain and instability and proximal migration of the radius.
That's a critical point. An elbow injury could be directly linked to a significant wrist problem. And then imaging. That must be key.
Imaging is fundamental, yes. Plain radiographs are always the first step. Standard AP and lateral views are essential.
Okay.
If the elbow is dislocated on arrival, you ideally need films before reduction and definitely after reduction to confirm concentric reduction of both the humerulnar and radiocapitellar joints.
How do you check that concentricity?
On the lateral view, a line drawn through the center of the radial neck should always pass through the center of the capitellum, regardless of the flexion angle. Any deviation suggests subluxation or malalignment. Radiographs can identify the dislocation and often show the significant radial head or coronoid fractures, but
they have limitations.
yes, they're often limited in showing complex bony detail, subtle displacement, or the exact size and shape of fragments, especially the coronoid.
So X-rays give you the initial picture, but for the full story, what else is needed?
That's where computed tomography, the CT scan, becomes absolutely invaluable. It's almost mandatory in complex elbow fracture dislocations like the terrible Triad.
Why is CT so crucial here?
CT provides detailed cross-sectional images and crucially allows for 3D reconstruction. This is vital for precisely characterizing the fracture patterns.
For example,
The size, shape, location, and displacement of the coronoid fragment, which can be much more complex than it appears on X-ray, particularly those tricky anteromedial facet fractures. It also details the comminution and displacement of the radial head fracture, any articular step-off, and helps identify any small bone fragments that might be trapped within the joint.
So it's like a blueprint for surgery.
Exactly. This detailed 3D blueprint is essential for accurate surgical planning. Fluoroscopy, using live X-ray under anesthesia, is also often used intraoperatively to dynamically assess the stability after the bony and ligamentous repairs have been performed.
Right, so the CT scan is the key to truly understanding the specific anatomy of the bony damage, which plain X-rays might easily miss. Combining that detailed imaging with the clinical picture allows you to confirm the diagnosis and plan the next steps.
Precisely. Diagnosis and planning are paramount.
Okay, once the diagnosis is made, you're faced with this really challenging multi-component problem. The dislocation, the radial head fracture, the coronoid fracture, and the extensive ligamentous disruption. The sources discuss various classification systems for the bony injuries. How do these systems help surgeons make sense of this chaos and, crucially, guide treatment decisions?
Classification is absolutely vital, yes. It helps standardize description and guide surgical management because different fracture patterns behave differently biomechanically and often require different fixation strategies.
Okay.
For coronoid fractures, the traditional classification is the Regan-Mori system. It's based simply on the height of the fragment seen on the lateral X-ray view. Type 1 is just the tip, Type 2 is less than 50% of the coronoid height, and Type 3 is more than 50% of the height.
Seems straightforward, but the sources noted a limitation there.
Yes, the main limitation of Regan-Mori is that it doesn't adequately capture the crucial three-dimensional location of the fracture, particularly those involving the anteromedial facet.
The bit where the MCL attaches?
Exactly. Those anteromedial facet fractures can be highly destabilizing, even if they aren't particularly large in height on the lateral view. The O'Driscoll classification addresses this much better.
How does O'Driscoll work?
It categorizes fractures based on their anatomical location. Type 1 involves the tip, type 2 involves the anteromedial facet, and type 3 involves the base of the coronoid. And there are subtypes within those.
And that's more useful surgically.
Yes, the O'Driscoll system is generally considered more useful for surgical decision-making because it directly relates the specific fracture pattern to the injured ligament attachment, like the MCL, on the anteromedial facet, and therefore informs the necessary fixation strategy and surgical approach.
That makes sense. Location dictates strategy. And for the radial head fracture, what systems are used there?
The Mason classification is the classic system, widely known. It's based purely on the radiological appearance. Type 1 is non-displaced. Type 2 is displaced but generally considered repairable, often causing a mechanical block to motion. And type 3 is comminuted, shattered into multiple pieces, typically not repairable. Johnson later added type 4 for any radial head fracture associated with an elbow dislocation, which is, of course, the pattern we see in a terrible triad.
And the Hotchkiss modification, how does that refine Mason?
The Hotchkiss modification builds on Mason by incorporating clinical findings and explicitly guiding treatment. It helps distinguish between fractures that might, very rarely, be treated non-surgically. Type 1, less than 2 millimeter displacement, no block.
Okay.
Those suitable for open reduction and internal fixation, or IF, type 2, more than 2 millimeter displacement, causing a block but still repairable.
Right.
And those requiring replacement, usually an arthroplasty, type 3 committed, not repairable. So it's a more clinically oriented and treatment-focused classification.
Are there any systems mentioned that try to classify the entire injury pattern, taking into account both the bones and the ligaments?
Yes, the wants it all. Wrightington classification is mentioned in the sources. It's based on the three-column concept of the elbow, a lateral column, a middle ulnar column, and a medial column. It classifies complex fracture dislocations based on which columns and their associated key ligaments are injured. In this system, a type C injury essentially aligns with the terrible triad pattern, involving significant disruption of both lateral and medial stability structures. So it helps frame the overall instability pattern.
So using these classification systems helps translate the complex imaging findings into categories that directly inform the treatment plan. What does that treatment plan typically look like? Is non-surgical management ever a realistic option for such an inherently unstable injury?
For the vast majority of terrible triad injuries, surgical management is necessary. Non-surgical treatment is only appropriate in extremely rare and select cases that meet very strict criteria.
Such as?
The elbow must be perfectly concentric, perfectly reduced after the initial reduction. The radial head and coronoid fractures must be very small and judged to be inherently stable.
Yeah.
And critically, there must be enough inherent stability to allow immediate, protected early range of motion without any risk of the elbow subluxating or redislocating.
So very specific circumstances.
Extremely specific. Even then, it involves maybe a week or so of immobilization, followed by a very cautious restricted motion protocol. Essentially, if there's any significant displacement of the fractures or any ongoing concern for instability, surgery is indicated, which is most cases.
So surgery is definitely the mainstay. What's the overarching goal of the surgery then?
The primary goal, the absolute key, is to restore enough stability to permit early motion.
Why is early motion so important?
Because prolonged immobilization leads to severe stiffness, which, as we've said, is the most common and often most debilitating complication. So surgery aims to fix the bony fractures and repair the torn ligaments reliably enough that the patient can safely start moving the elbow actively within just a few days.
Okay.
The sources describe the principle of inside outward, or perhaps more commonly, lateral to medial repair. This involves addressing the lateral structures first, then the bone, and finally addressing the medial side only if instability persists, sequentially restoring stability.
Let's delve into the surgical procedures mentioned in the sources. What are the common approaches the incisions use to get to these structures?
Surgeons typically use either separate approaches or sometimes a single larger approach, depending on the specific injury pattern and their preference. A direct lateral approach provides excellent access to the radial head and the LCL complex.
Okay.
A medial approach gives access to the MCL and also allows for fixation of some coronoid fractures, particularly those anteromedial facet ones.
Right.
Alternatively, a universal posterior approach, often using a technique that spares or reflects the triceps tendon, can allow access to both the medial and lateral columns through a single large incision. Some specific coronoid fractures might even require an additional small anterior approach for fixation. The choice really depends on the surgeon's experience and the specific fractures needing fixation.
And the specific techniques for fixing the bony and ligamentous injuries, let's start with the radial head.
Okay. For the radial head, if it's deemed repairable, generally fitting the Mason Type 2 or Hotchkiss Type 2 criteria, meaning usually less than 3 or 4 pieces, less than 40% of the articular surface involved, and displaced.
Then ORF.
Yes, then open reduction and internal fixation, ORAF, is performed using small, specialized screws and sometimes plates. The sources emphasize the importance of careful screw or plate placement within the safe zone.
The safe zone, what's that?
That's the posterolateral aspect of the radial head, roughly a 90 to 110-degree arc measured from the radial styloid when the forearm is held in neutral rotation. Placing hardware here minimizes the risk of it impinging on the ulna or humerus during pronation and supination and reduces risk to the posterior interosseous nerve.
Okay, crucial detail. What if the radial head is just too shattered to repair? Mason type 3.
If it's severely comminuted, Mason Type 3, Hotchkiss Type 3, typically more than 3 or 4 fragments, basically irreparable, then it's usually replaced with a radial head arthroplasty. That's a metal implant that mimics the shape of the radial head.
And sizing is important here.
Absolutely critical. Sources stress that meticulous attention must be paid to implant sizing. An implant that is too long or over-lengthened can cause significant pain, stiffness by overstuffing the joint, and wear on the capitellum.
And too short.
An implant that is too short or undersized will simply not provide adequate stability. It won't restore the secondary valgus and rotational restraint. The goal is usually to seat the radial head implant approximately 2 millimeter distal to the tip of the native coronoid process.
Right. And the sources were very clear about not just removing the radial head.
Extremely clear. Radial head resection, just cutting it out and leaving nothing, is generally strongly contraindicated in unstable or dislocated elbows like the terrible Triad. It removes a key secondary stabilizer, massively increasing the risk of proximal migration of the radius over time, leading to wrist problems that Essex-Lopresti issue again.
That's a really critical point about not just removing it if it's broken and the elbow's unstable. Okay, what about the coronoid fracture? How is that fixed?
Coronoid fixation techniques vary quite a bit based on the fracture size and location, often guided by that O'Driscoll classification. Smaller tip fractures, type 1, might be fixed with sutures passed through drill holes in the ulna, or sometimes using suture anchors. Occasionally, they can even be lassoed with sutures passed through a radial head implant if one is being used.
And bigger fragments?
Larger fragments, especially those involving the anteromedial facet or the base of the coronoid, O'Driscoll type 2 or 3, typically require more robust fixation with screws or even small plates for stability. These fractures can sometimes be quite challenging to access and fix directly, requiring specific surgical approaches.
Right. And finally, the torn ligaments, the LCL and maybe the MCL.
The LCL complex is nearly always injured and requires repair. It's typically repaired by reattaching it anatomically back to its origin on the lateral epicondyle. Often, it's avulsed as a sleeve of tissue from the bone.
How is it reattached?
Suture anchors, small implants drilled into the bone with strong sutures attached, are commonly used to resecure the ligament footprint back to the bone, typically centered around the axis of rotation near the center of the capitellar curvature.
And the forearm position matters during LCL repair.
Yes, the forearm position during the LCL repair is important. Sources suggest repairing the LCL with the forearm held in pronation if the MCL is intact. Pronation tends to tighten the LCL and helps reduce that posterolateral rotation.
And if the MCL is also torn,
If the MCL is also significantly injured and requires repair, then the LCL is usually repaired with the forearm held in supination or perhaps neutral rotation to allow appropriate tensioning of both ligaments simultaneously.
and is the MCL always repaired?
Not always. The MCL itself is typically repaired only if the elbow remains unstable after fixing the bony injuries and repairing the LCL. Instability is often checked dynamically under anesthesia, particularly looking for gapping on the medial side when the valgus stress is applied, especially in extension beyond 30 degrees. If it's still unstable, then the MCL needs repair too.
Okay, that's a lot of complex repair work. What if, even after fixing the bone and repairing the ligaments, the elbow still doesn't feel stable enough for that crucial early motion?
That's a challenging situation, indicating persistent growth instability. In such cases, some form of supplementary stabilization might be required temporarily.
Like what?
This could involve applying a hinged external fixator. This is a frame outside the arm, connected by pins above and below the elbow, that allows controlled motion within a set range, but protects the internal repairs by spanning the joint externally.
Are there other options?
Static external fixators rigidly hold the joint in one position, usually flexion, but carry a much higher risk of stiffness due to the complete immobilization. Internal joint stabilizer devices are also an option, implants placed across the joint internally, but they often require a second surgery for removal and have their own potential complications. Cross-kitting the humeral ulnar joint in a reduced position with temporary wires is also mentioned in one source as a possibility for very short-term stability. But the goal is always to achieve enough primary stability from the internal repairs to allow that early motion, if at all possible.
It's clearly a very complex surgical undertaking involving multiple intricate repairs. The timing of the surgery is also something highlighted quite strongly in the sources.
Yes, this seems to be a critical factor impacting the final outcome. Several sources emphasize that delayed surgery, particularly if it's performed more than 14 days after the initial injury, is associated with significantly higher rates of stiffness and generally poorer functional outcomes compared to surgery performed within a shorter time frame.
Sooner is better.
Generally, yes. Surgery performed ideally within 24 hours up to perhaps 14 days seems preferable. Early anatomical reduction and scalable fixation appear to interrupt the inflammatory and scarring processes that lead to severe joint contracture and potentially heterotopic ossification,
Which means
which means accurate and timely diagnosis, often requiring that prompt CT scanning we discussed, is key not just for planning the surgery, but for facilitating early surgical intervention to improve the chances of a good outcome.
so diagnose quickly, operate comprehensively and in a timely manner, and then what? What's the crucial next step in the patient's journey towards regaining function?
Postoperative rehabilitation. It is absolutely paramount and, in many ways, equally as challenging as the surgery itself.
Why so challenging?
It's a very delicate balancing act between protecting the surgical repairs, which need time to heal, and regaining motion to prevent stiffness.
How is that balance managed initially?
Initial immobilization is kept to an absolute minimum, usually just 7 to 10 days. The elbow is typically held in a splinter brace at around 90 degrees of flexion, potentially with specific forearm rotation pronation or neutral, depending on which ligaments were repaired and how.
And after that brief period, what happens then?
Early active motion is initiated very quickly, often within 48 hours, or at least within a few days postoperatively, once the initial pain and swelling start to settle.
Active motion. So the patient moves the elbow themselves.
Yes, gentle active range of motion. Studies strongly support that initiating this as soon as stability permits significantly improves functional outcomes and is the best strategy we have to combat stiffness. Patients are typically guided by a therapist through controlled flexion and extension within a safe, prescribed arc of motion.
Are there any specific movements or ranges to avoid initially to protect the repairs?
Yes, often patients are advised to avoid achieving full or near full extension, particularly the last 30 degrees or so of extension for the first few weeks, typically around 4 weeks.
Why avoid full extension?
That terminal extension position can put significant stress on the healing LCL and potentially the MCL repairs, depending on the specific pattern of instability. Avoiding it helps protect the reconstruction during the early healing phase. Strengthening exercises are introduced much more gradually, usually starting around 6 to 8 weeks post-op.
What sort of strengthening?
Beginning with low-resistance activities like gentle wall push-ups or weight-bearing on the hands in a quadruped, all-fours position, progressing slowly as tolerated and as healing progresses.
This clearly requires close collaboration and expert guidance.
Absolutely. A dedicated physiotherapist, ideally one experienced with complex elbow injuries, plays a vital role throughout the entire rehabilitation process. They guide the patient, monitor progress, adjust the program based on response, and manage expectations.
And how is success measured?
Functional outcomes are commonly tracked using validated questionnaires like the DASH score disabilities of the arm, shoulder, and hand, and the MEPS, the Mayo Elbow Performance Score. MEPS scores range from 0 to 100, with scores of 90 to 100 indicating an excellent functional result.
Despite the best surgery and dedicated rehab, what are the potential setbacks or complications that patients and surgeons might still encounter? This injury sounds like it can fight back.
Unfortunately, yes. Given the severity of the initial trauma and the complexity of the reconstruction, complications are relatively common, even with optimal management. Stiffness is arguably the most frequent, significant complication.
Stiffness again.
Yes, reported incidences range from 5% up to as high as 15% or even more in some series, requiring further intervention. It often presents as a significant loss of extension, a flexion contracture. It can be caused by excessive scar tissue formation within and around the joint, or by heterotopic ossification. Ulnar nerve irritation or entrapment is also a significant risk factor for pain and can contribute to limiting motion.
Heterotopic ossification, that's the abnormal bone growth outside the normal skeleton you mentioned earlier.
Yes, exactly. HO is a major concern after these complex elbow injuries. Its incidence in operatively treated terrible triads can be disturbingly high, reported up to 43% radiographically in some studies, though not all of that is clinically significant.
What causes it?
HO seems associated with the severity of the initial soft tissue injury, the amount of tissue damage during surgery, prolonged immobilization, any associated nerve injury, infection, and significantly delayed surgical intervention seems to increase the risk.
When does it appear?
It typically appears radiographically within 3 to 4 weeks post-injury and can cause really severe restrictions in range of motion, potentially leading to ankylosis, which is complete fusion of the joint in the worst cases. Excision of the HO may be required later on, but that's a complex procedure itself with risks.
Is there anything done to prevent HO?
Sources discuss prophylaxis, like using anti-inflammatory drugs such as indomethacin, but note the evidence for its effectiveness specifically in traumatic elbow HO is still debated. Radiation prophylaxis is sometimes used, particularly after HO excision, but it's often considered too risky after the initial fracture surgery due to potential negative effects on fracture healing, though it is mentioned for severe burn patients with associated elbow injuries.
So, HO is a significant potential hurdle. What else is on the complication list after terrible triad surgery?
Well, recurrent instability is another risk. This can happen if the initial surgical repairs fail, perhaps the fixation wasn't robust enough, or if subtle injuries, especially smaller coronoid fractures, were underestimated or inadequately fixed initially.
Infection.
Infection is a serious concern, especially with implants present. Rates have been reported up to 17.5% in some older series, which can be devastating, often requiring multiple further surgeries.
Nerve problems.
Nerve injuries, such as ulnar or radial nerve, specifically the posterior interosseous branch, entrapments or palsies, can occur in up to 23.5% of cases according to some sources. These can be due to the initial injury, swelling, scar tissue formation later on, or sometimes proximity to surgical hardware.
And other issues.
Non-union or malunion of the fractures, meaning they don't heal or heal in a bad position. Post-traumatic arthritis or degenerative joint disease is a long-term risk due to the initial cartilage damage sustained at the time of injury or due to residual instability or joint incongruity. And issues related to the hardware itself, painful, prominent, or loose implants sometimes requiring removal, are also potential complications. It really underscores why this injury pattern is so challenging to manage comprehensively.
Given all those potential issues, what's the realistic long-term outlook? What can someone generally expect in terms of prognosis after navigating this very difficult injury and its treatment?
Historically, as the name terrible triad implied, the prognosis was often poor. High rates of chronic pain, significant stiffness, limiting function, and persistent instability leading to disability were common.
But things have improved.
Yes, thankfully, with significant advancements in our understanding, better imaging, modern surgical techniques, particularly more stable fixation methods, and reliable radial head replacement options, and structured early rehabilitation protocols, the outcomes have substantially improved. Generally, good to excellent functional results, as measured by those MEPs and DASH scores, often averaging above 75, are now achievable for many patients.
So the terrible aspect is perhaps less about the inevitable outcome nowadays and more about the complexity of the injury and its management.
Precisely. I think that's a fair summary. With appropriate, timely, and skilled care, it is often possible to achieve a good functional outcome, allowing return to most activities.
What predicts a better outcome?
The sources consistently highlight that key predictors of a better prognosis include accurate and timely diagnosis, often relying on that crucial CT scan, prompt surgical reduction and stable fixation or replacement that allows for early protected motion, and, very importantly, adherence to a rigorous, therapist-guided post-operative rehabilitation program.
But it's important to have realistic expectations.
Yes, absolutely. It's also important for patients to have realistic expectations. Achieving a completely normal elbow with full symmetrical range of motion compared to the uninjured side is actually quite rare, even with optimal treatment.
What sort of range is typical?
Sources consistently cite average functional arcs of motion after surgery, typically around 110 to 115 degrees of combined flexion and extension. Often there's some degree of flexion contracture, a loss of full extension, maybe 10, 15, even 20 degrees, that persists. While not fully normal, this range of motion is usually sufficient for most activities of daily living.
So it sounds like aiming for a highly functional elbow rather than a perfectly normal one is the realistic goal.
That's often the case, yes. Maximizing function within the limits imposed by the injury.
The sources also suggested that where you receive care might matter, the experience level.
Yes, that was noted. Some sources, including the one from the Mayo Clinic, have reported better outcomes in these highly complex cases when managed at higher volume centers by surgeons who have significant experience specifically in complex elbow trauma and reconstruction.
It makes sense.
The technical demands of these surgeries, the nuances of fixation, implant choice, ligament repair, and the careful orchestration of post-operative management likely benefit from that focused experience.
That was a truly deep dive into a remarkably challenging injury. Let's try and consolidate some key facts with our lightning round. Quick questions, sharp answers based purely on the sources we've explored today. Ready?
Ready when you are.
Okay. What are the three essential structural components defining a terrible triad injury?
That's the posterior elbow dislocation, the radial head or neck fracture, and the coronoid process fracture.
Which classification system for coronoid fractures is generally considered most useful for guiding surgical planning, and why?
That would be the O'Driscoll classification, because it's based on the anatomical location, the tip, anteromedial facet, or base, which directly dictates the surgical approach and the fixation strategy needed.
For severely comminuted, irreparable radial head fracture in a terrible triad, what is the usual surgical treatment?
Radial head arthroplasty, so replacement of the radial head with an implant.
What forearm position is often recommended during LCL repair if the MCL is intact, and what's the reasoning?
Pronation is often recommended because pronation tensions the LCL and helps to reduce that tendency towards posterolateral rotation.
What is the most common major complication encountered after surgical fixation of a terrible triad injury?
Stiffness, or loss of motion, often due to scar tissue, capsular contracture, or sometimes heterotopic ossification.
And what specific type of imaging is considered essential beyond plain X-rays for effective surgical planning?
Computed tomography, the CT scan, especially valuable with 3D reconstruction views.
Excellent. Those cover the core factual anchors from our comprehensive sources.
Yeah, all right.
To try and summarize this very complex topic into practical takeaways for you, our listener, here are 5 key points from this deep dive into terrible triad injuries. First, always maintain a high index of suspicion for a terrible triad following any elbow dislocation. It's a specific and severe pattern. Don't underestimate it.
Crucial first step.
Second, detailed imaging, particularly a CT scan, often with 3D reconstruction, is vital for accurately characterizing the complex bony injuries and planning the appropriate surgical intervention.
Can't plan without the full picture.
Third, surgical treatment is necessary in nearly all cases. The main goal is to restore stability, fixing both bone and ligaments reliably enough to allow immediate, protected early range of motion.
Stability for motion is key.
Fourth, timely surgical management, ideally within about 14 days of the injury, combined with a rigorous early post-operative rehabilitation program focused on controlled motion, are absolutely critical for optimizing recovery and minimizing that dreaded complication of stiffness.
Timing and rehab are paramount.
And fifth, given the intricate nature of these injuries and their demanding management, seeking care from orthopedic surgeons or centers with specific experience in complex elbow trauma can significantly influence the potential outcomes.
Experience likely matters here.
That brings us towards the close of this deep dive into the terrible triad. If you found this discussion valuable and insightful, please do consider rating and sharing the show on LinkedIn or X. And thank you immensely for guiding us through this really challenging orthopedic topic with such clarity and detail.
It was my pleasure. A fascinating and important injury to discuss.
As we conclude, here's a final thought for you to reflect on, drawing directly from the sources we've explored. Despite considerable advances in our understanding and techniques, the management of terrible triad injuries remains a profound balancing act.
It truly does.
It's a continuous effort by the surgical and therapy teams to achieve just enough stability to prevent redislocation and allow healing, while simultaneously allowing enough early motion to regain functional use and fight off stiffness. The patient's entire journey involves navigating this fine line, where the ultimate outcome really hinges on the success of both the initial surgical reconstruction and their dedicated long-term rehabilitation.
A partnership between surgeon, therapist, and patient.
Until next time, keep diving deep.